Walking is, of course, a wonderful activity. Not only is it functional, but it provides so many benefits to our bodies. I really like the work of Shane O'Mara. He's a neuroscientist who wrote the book In Praise of Walking, and it details the myriad benefits it has on our bodies. But when it comes to orthopedic disorders and walking, it can be a different story. That is, some patients, their disorders become more symptomatic the more they walk. So here are a few things that I'm thinking about when it comes to walking and orthopedic disorders. Let's take the spine. In normal standing or walking, the spine is in a neutral to extended posture. So I'm talking about that type of person. I'm not talking about the person who is flexed forward in a stooped posture with walking. For the normal spine that's in neutral to extended with walking, if someone says their symptoms are worse, wherever they may be with walking, and it's coming from the spine, or I'm thinking the likelihood is that the extremity or the spine symptom is coming from the spine, I start to wonder, is it the weight bearing or the gravity on the spine that is problematic for this individual, or is it the neutral to extended position of the spine? Meaning, if someone gets worse with that slightly extended posture, maybe if there's a mechanical joint problem in the spine, we need to look at flexion, or we need to look at a movement in the transverse or frontal plane. So that's how I'm thinking about directional preference and what positions and postures and movements make people better and what make people worse. Another thing I'm thinking when it comes to the lower extremities is if someone has a complaint that's in the buttock down to the toes, so not necessarily in the spine, and they report that the more they walk, it gets better, that raises the likelihood to me of the disorder emanating from the lower back or mid back. That is, I don't hear a lot of people with hip disorders, knee disorders, ankle disorders, foot disorders, etc., that report the more I walk on it, the better it gets. It does happen, but in my mind, when I'm listening to that verbal history, that slightly raises the prevalence that it's going to be a problem where the disorder's in the spine and it's referring or creating radicular symptoms into the lower extremity. Now, if that patient says the more I walk, the symptoms were in my lower extremity, they move to my back. Or if I'm sitting, the symptoms are in my lower extremity, but when I walk, the symptoms are in my back, they are reporting centralization, probably. So we need to investigate again. Is that position of the spine and walking neutral to extended posture? Is that creating the centralization? And if it is, that makes me think that the patient would likely benefit from more extension. So I'll start my repeated movement testing there. Again, the specific verbal history is part 1 of my orthopedic evaluation. Part 2 is when I decide what baselines do I need to take? Where do I need to get range of motion? Where do I need to measure strength? What nerves do I need to test? And what functional baselines would be apropos for this individual? Those 2 main parts tell me where it would be most effective to start repeated movement testing if I want to use repeated movement testing with this patient. For almost all patients, I think it's appropriate to use repeated movement testing, but for some patients, it's not indicated. They may need to go directly to imaging, or we may need ligamentous testing, or testing that doesn't really look at mechanics of the joint. So, listening for centralization or peripheralization is important. Peripheralization would be someone who says, my pain's in my back when I go for a walk when I start, and the more I walk, it starts radiating into my buttock, or it starts referring down to my knee, or it doesn't refer in a straight line, but the more I walk, the back pain stays there, and then it starts presenting in my calf. So those are the kinds of questions I'm listening for, and again, it goes back to my thought process of, is it the weight bearing through the spine? Is it the position of neutral to extension of the spine? Is it telling me that this is more likely a spine disorder versus a lower extremity disorder because the more they walk, their hip feels better, and that's not what I would expect in most cases for a true hip disorder. Those are some of the things that I'm thinking about when it comes to walking, and that also applies kind of to the upper extremities in a sense, because the upper extremities are not obviously weight bearing in walking, and they're not doing too much work. So if a patient's arm pain returns to the neck or centralizes to the neck the more they walk, that would likely make me want to investigate extension of the neck first because of that neutral to extended posture of the neck in walking. Again, I'm not talking about the people who are looking over their phones in flexion or who are flexed when they're walking. So just like any activity, I'm asking about in the specific verbal history, what happens the longer you sit, what happens when you run, what happens when you walk, what happens when you lie down, what happens when you get up. They're giving me clues as to the diagnosis because I want to have the most information from the beginning to go into parts 2 and 3 to make them as effective as possible. Now, when I also think about running and walking, they're quite similar in this regard. Running will be slightly more extension usually of the lower back than walking, but it gives me the same kind of idea. If the more I run, my knee pain gets better, well, then I'm very curious about your spine. Or if the more I run, the back pain comes on, well, then I'm curious if it's a spinal joint disorder that needs a non-extension movement. So listen for these things in the verbal history. And if you're a patient who's experiencing symptoms, this might clue you in as to, okay, if this is mechanical and has a solution, then we're looking for the directional preference. We're looking for the direction that I need to get better. So if I understand which directions make me worse, they give me clues as to which ones might be more likely to be helpful. Maybe the opposite of what makes you worse or more of what makes you better. Not all orthopedic disorders are mechanical joint disorders, of course, but I find 70 to 80% of them are. And for the patient who obviously says, I hurt my ankle and the more I walk, it hurts more and more and more, and all the other tests prove that this is ligamentous or prove that this is bone, that's the diagnosis. But most people have joints that aren't moving perfectly well. They create limited and or painful range of motion. They create weakness in muscles. They create nerve tension. And of course, they create functional problems. The inability to sit without the pain. The inability to roll over in bed or lie without pain. Those disorders fit that category, having those signs and or symptoms that can be local and or referred, and they're reversed and abolished by moving in the right direction repeatedly. And my job as a clinician is to make sure if that's the diagnosis or not, and if it is, to help the patient find the direction that they need. Because it can be different. For some people, their joints respond to maybe extension of the neck and sitting, but other people respond to extension of the neck off a table and supine. So there's differences. Robin McKenzie's books, Treat Your Own Back, Treat Your Own Neck, Hip, Knee. There's a new one with the ankle, shoulder, etc. They can help people self-assess and self-treat. But clinicians who are versed in McKenzie's work, in addition to all the other orthopedic principles that we learn in school, should be able to help you figure out if your disorder is mechanical, and if it is, which direction you need to get back on track.